Hello friends, in this edition of Nephrologists for the non-nephrologists, I'll be talking about approach to nephrotic syndrome in children. And I also share with you some of the work that I've been involved in the last 3 decades. Now, when I started my career in nephrotic syndrome, I was reminded of this quote by Voltaire, that doctors are men who prescribe medicines of which they know little to cure diseases of which they know less in human beings of whom they know nothing. We didn't know at that time why nephrotic syndrome occurred. We used to treat them with steroids, and if they did not respond to steroids, we had cyclophosphamide and sometimes levamisole. Other than that, there was very little we could do, and a lot of these children progressed to kidney damage. Now, I'll be talking about nephrotic syndrome first, then look at management of steroid-sensitive nephrotic syndrome and steroid-resistant nephrotic syndrome, and share with you some of the actual cases that I've managed, as patients are our biggest teachers. So this is how we approach proteinuria. So you test, if a single sample tests positive for protein, we repeat twice, and only the first urine sample test is positive. We just follow up these children. If 2 or more samples are positive, we look at the kidney functions, we look at complete blood count, complement levels, urine protein creatinine ratio. If these test results are abnormal, urine protein creatinine ratio is greater than 3. If its child is under 6 years of age, corticosteroid therapy can be given. If child is more than 6 years, it is better to involve a pediatric nephrologist, especially if there is hematuria or low C3 level or low EGFR. If there are normal laboratory results in children under more than 6 years of age, you test for orthostatic proteinuria. Under 6 years of age, look at ultrasound. Orthostatic proteinuria is negative. Make sure an ultrasound is done. Involve a pediatric nephrologist. If the orthostatic proteinuria is positive, then just an annual follow-up suffices. Now, as we understand today, nephrotic syndrome is a podocytopathy. This is an electron photomicrograph or the glomerular filtration processes with the interdigitating podocytes, and this is the glomerular filtration barrier. Disruption of this filtration barrier due to any cause, intrinsic, metabolic, genetic, or extrinsic like hemodynamic, immune or infectious, can result in proteinuria. In nephrotic syndrome, there is a phasement of these food processes, because of which the filtration barrier is disrupted, leading to massive protein leakage around the cell into the urine. So you have proteinuria, you have hypoproteinemia, you have anosarca, and you have hypercholesterolemia. Now, this is how you look at nephrotic syndrome. Make sure it is idiopathic. If it is steroid-sensitive nephrotic syndrome, it is believed there is a disimmune nephrotic syndrome. There is perhaps a circulating factor of glomerular permeability. And by and large, in the vast majority, no monogenic cause can be identified. If it's a steroid-resistant nephrotic syndrome, this is a heterogeneous subset. You could have a subgroup who respond completely, get into remission with intensified immunosuppressive therapy, but then these patients can recur after transplant, and here again there is a disimmune nephrotic syndrome, and there is perhaps a circulating factor of glomerular permeability. You have another subset of steroid-resistant nephrotic syndrome, which is monogenic nephrotic syndrome, and there are structural abnormalities of the glomerular filtration barrier. Numerous proteins have been identified. It could be congenital nephrotic syndrome, steroid-resistant nephrotic syndrome, autosomal dominant FSGS, and partial remission may be achieved with CNIs in a subgroup of these patients. So if you see a child with nephrotic syndrome, you would first try and identify, is it the first episode or is it a relapsing child? If relapsing, if it's an infrequent relapser or a frequent relapser, steroid dependent or a steroid resistant. This could be either an initial non-responder, that is primary steroid resistant, or secondary non-responder, which is secondary steroid resistant. These are what the KDIGO guidelines tell us, that if it's a steroid-sensitive nephrotic syndrome, first episode, steroid therapy should be given for 8 to 12 weeks, and this should be given orally in a dose of 60 milligram per square meter per day or 2 milligram per kg per day to a maximum dose of 60 milligram per day, and it can be given as a single dose preferably. Now, if it's a relapse, then we treat it with a much shorter course, 60 milligram per square meter daily till remission, followed by 40 milligram per square meter alternate day for the next 4 weeks. And for children with frequent relaxing and steroid-dependent nephrotic syndrome who are currently taking alternate day steroids or are off steroids, we recommend that these are the KDIGO guidelines that daily steroids in a dose of 0.5 milligram per kg per day can be given during episodes of upper respiratory tract infections for 5 to 7 days. So it's just about a 1 week of therapy if it's a URTI triggered relapse, and if they respond, you can stop abruptly. So this is a new change in the 2021 guidelines. Now, can we outdo this gentleman on the street and try and predict which patients are difficult? Yes, there are certain clinical markers, certain histopathological markers, and there are now genetic markers available, and we'll see which of these are there. So this is one of our earliest studies, which we published in Acta Pediatrica, and what we found that if the age of onset was more than 4 years, and less than 8 years, these children tend to do well. But if it was less than 4 years or more than 8 years, if it were males, if it was a combination of hypertension and microscopic hematuria, and if the biopsy showed non-minimal change lesions, these children tend to do poorly. Subsequent studies published in CJAS in 2013 validated our criteria, but also added that if the remission time is more than 9 days in the first episode, then again, these children tend to do poorly. And if first relapse occurred within 6 months of steroid therapy, then again, these children have a difficult course. So this is a simple therapeutic approach, which we outlined in a paper published in Acta Pediatrica 1992. So all children should be subjected to standard prednisone therapy, and thereafter you can classify these children into the steroid response categories. 1/3 of these patients will be non-relapsers, another 10 to 20 would be infrequent relapsers, which means less than 2 relapses over 6 months. 20 to 30 would be frequent relapsers, more than 2 relapses over 6 months. Another 20 to 30 would be steroid dependent who relapse while on steroid therapy or within 2 weeks of stoppage of steroid therapy. And 5 to 10% would be steroid resistant. Most of them would be initial non-responders, that is no remission following 4 weeks of prednisone therapy, but there would be a small subgroup of patients who are secondary non-responders, that is, who have previously had a relapsing course but now become steroid resistant. Now, this approach has been found to be of diagnostic value because it predicts minimal change with a high degree if the children are steroid sensitive. It's of therapeutic value again, because if you have steroid sensitivity, it predicts response to other agents like cyclophosphamide, levamisole, mycophenolate, and it's of prognostic value as the prognosis in steroid-resistant patients is much poorer in the other subgroups. So therefore, you don't need to do a biopsy at the onset in these children, and the steroid response categories have a much greater degree of prognostic value than the biopsy itself. Now, these are the common causes of nephrotic syndrome in children, and they vary from minimal change to focal segmental glomerulosclerosis. 80 to 90% of these children have got minimal change disease, which could be non-relapsing, infrequent, frequent relapsing, steroid dependent, and very rarely steroid resistant. Focal segmental glomerulosclerosis patients could be steroid resistant, but some of these patients would fall in these category, and some people believe that these are different ends of the same spectrum of disease. So there are multiple etiologies, but 90% are steroid sensitive, and that's why the steroid response category is much more important than the histopathology. So these are the 3 common histopathologies: minimal change, mesangial proliferative glomerulonephritis, and focal segmental glomerulosclerosis. This is a normal looking glomerulus. There is no changes. As you can see, cellularity is normal. There's no sclerosis. And on electron microscope, the only change is diffuse effacement of the podocytic foot processes. And this is minimal change disease. This is focal segmental glomerulosclerosis. And in this, you can see here at this area that there is an area of sclerosis here, and that is a hallmark of FSGS. Now, this is a slide from paper published in Lancet, looking at the prevalence of FSGS over 2 different time periods. Includes studies from different parts of the world, including ours from India, which showed that over these 2 time periods, the FSGS prevalence nearly doubled. Similar reports from USA, North America, Hong Kong, Saudi Arabia. We are not sure what is the cause, but it could be either an environmental or an infectious etiology. Genetics have been a promising marker for predicting response. One of the earliest studies published in pediatric nephrology from our center, which we found that if these children had this allele called HLA-DQ beta 102, they were more likely to develop nephrotic syndrome as compared to the general population, whereas the presence of HLA-DR beta 101, DR beta 130X, and DR beta 103 had a protective effect. The allele DR beta 150X was a marker of steroid resistance in our experience, and the hypothetical susceptibility gene for steroid resistant nephrotic syndrome could be located near or in the DR beta 150X TQ beta 106X haplotype. Genetics has come up in a big way in predicting response, and we are identifying more and more genes now and more proteins. The number is growing, but by far it is most of these are patients of steroid resistant nephrotic syndrome. In the vast majority of patients of steroid sensitive nephrotic syndrome, there is no gene that has been identified. This is the slit diaphragm, these various genes here, and this is the long list that is there. And this is now emerging as a very important test in children. Now, looking at immunosuppression in steroid-sensitive nephrotic syndrome, alkylating agents are, I think, one of the most promising agents. 50% decrease in the risk of relapse of 1 to 2 years during and after treatment, and the benefits are sustained even after stopping therapy. CNIs and levamisole, in contrast, the benefit is there only during therapy, and these children tend to relapse after stopping therapy. So we'll take these agents one by one. Levamisole, I think, is one of the cheapest agent, very innocuous, low cost, but also very low degree of side effects. We use it in a dose of 2.5 milligram per kg alternate day for about 12 to 18 months, minimal side effects, and it's been found to be useful in frequent relapsing children. Alkylating agents, especially cyclophosphamide, not recommended in the first 2 years of life because of concerns of gonadotropicity and gonadal development. So therefore, levamisole would be the agent of choice under 2 years, but beyond 2 years, it's one of the most effective agents. 65% remission at 5 years. Half of these children undergo permanent remission, and the usual dose is about 2 milligram per kg per day for about 8 weeks. Make sure you keep well below 200 milligram per kg, at which gonadotropicity is seen. So I think a safer dose is about 168 milligram per kg. I'll share with you some of the cases. This is a 17-year-old boy, idiopathic nephrotic syndrome, which was steroid dependent. In 1993, we treated him with intravenous rather than oral cyclophosphamide, monthly infusion for 6 months. Thereafter, I had one relapse in 1995, and thereafter subsequently has been in sustained remission. And this is what I call it: come in, get it, and forget it approach. So these children come in, they get this infusion over 3 hours, excellent compliance, not burdened with daily cyclophosphamide therapy, and more importantly, we end up giving a much lower dose, no alopecia, very well tolerated. And this is our paper which was published in Pediatric Nephrology Dialysis Transplantation, looking at intravenous cyclophosphamide in frequent relapsing and steroid-dependent nephrotic syndrome. So in the steroid-dependent category, we found that 42% of these patients attained complete remission, 31% of them became improved and became infrequent relapses, 17% improved and became frequent relapses, and 10% continued to be steroid dependent. This was after a mean follow-up of nearly 4 years. In the frequent relapsing category, the response was even better. 68% of these patients entered complete remission, 18% became infrequent relapses, 14% continued to have frequent relapses after a mean follow-up of nearly 3 years. Mycophenolate is another agent. It acts by inhibiting purine biosynthesis by inhibition of the enzyme IMPDH, inhibits DNA and RNA, inhibits B and T lymphocyte proliferation. The usual dose to be used is about 1200 milligram per square meter daily. The first paper by Hogg et al. Showed that 1/4 of these children of frequently relapsing nephrotic syndrome got sustained remission. However, in steroid-resistant nephrotic syndrome, it's not been that promising, and Dr. Baga's paper published in 2003 showed that majority of these children do tend to relapse after stopping therapy. But the unique role is in cyclosporin-dependent nephrotic syndrome. So if you use CNIs and these children tend to become cyclosporin-dependent, you can add on mycophenolate and then reduce and stop sienna and a mycophenolate cover, as is shown in this paper, Ilitsky et al. In 2005. This is one of our patients who had nephrotic syndrome at 2.5 years of age. He was steroid resistant. Biopsy showed mesangial proliferative glomerulonephritis. So we used cyclosporin for 2 years, went into remission. But thereafter, whenever we attempted to taper this, this child used to relapse. So he was cyclosporin dependent. So thereafter, I added mycophenolate, and after 1 year of mycophenolate therapy under cover of this therapy, we could taper cyclosporin and stop. And post mycophenolate, he's had a sustained remission. So to sum up, as far as this management of steroid-sensitive nephrotic syndrome is concerned, we prevent a relapse occurring with prolonged initial therapy. About 8 to 12 weeks is what currently the KDIGO recommends. Treat the initial or rare relapses with shorter courses of steroids. Then for frequent relapses or steroid-dependent patient, you could use either levamisole, cyclophosphamide. If the child is steroid sensitive or steroid dependent, you can consider low dose, long term, but intermittent cyclosporin or tacrolimus with steroids. And rituximab is a rescue therapy in children with complicated steroid dependent or cyclosporin dependent nephrotic syndrome. And we'll revisit this rituximab later. Now, nephrotic syndrome children are very difficult to manage, and I'm reminded of this quote by Louis Barnes, who said that few diseases tax the resources of the practitioner so extensively as the nephrotic syndrome. He must be a combination of an infectious disease expert, nutritionist, physiologist, psychiatrist, pediatrician, and nephrologist for the patient, and above all, guide, counselor, and friend to parents. A word about steroid-resistant nephrotic syndrome. So this is how we define steroid-resistant nephrotic syndrome as per the Indian Pediatric Nephrology Group consensus statement published in Indian Pediatrics 2001. I was a member of this expert group. So no response following 4 weeks of standard prednisone therapy in the absence of underlying infection. And this is slightly different from adults, where we take about 4 months of prednisone therapy to define steroid resistance. And this is what the reason is. In children, majority of 90% of these children who show eventual response will respond by 4 weeks. Very few respond beyond 4 weeks. And since we have not done biopsies, we use this 4 weeks cutoff. Whereas in adults, as you can see, there is a slow and progressive increase in the response rate right up to 16 weeks. That's why the definitions are different. Now, this is a paper on the histopathology of steroid-resistant nephrotic syndrome, published in Indian Pediatrics 2006. This is the ISKDC study, and our own study showed that focal segmental glomerulonephrosis was in fact the commonest cause of steroid-resistant nephrotic syndrome, followed by membranoproliferative glomerulonephritis, minimal change disease, diffuse mesangial hypercellularity, but the prevalence of focal segmental glomerulonephrosis was much higher than in the landmark ISKDC study, again mirroring our initial paper showing that the FSGS prevalence was increasing. So this is one girl who had nephrotic syndrome at 16 years of age. She did not respond to 4 weeks of prednisone. We biopsied her. The biopsy showed minimal change disease, and thereafter treated her with monthly infusions of cyclophosphamide for 6 months. Initially, oral prednisone was given, which was tapered off. So it was a combination of oral prednisone and intravenous cyclophosphamide. And thereafter, she has been in sustained remission. She comes occasionally for a social visit. She is now 30 years old, married, has a family, and you can see how well she has responded. This is perhaps the only randomized controlled trial of intravenous versus oral cyclophosphamide in steroid-resistant minimal change disease, which we published in Pediatric Nephrology 1994. A very small subgroup, 7 patients in the intravenous cyclophosphamide arm, all of them responded. 25% responded to oral cyclophosphamide. The dose with intravenous cyclophosphamide was much lower, 90 milligrams per kg, as compared to 150 milligrams per kg with the oral cyclophosphamide. Very well tolerated. Just vomiting was the only side effect. We saw no nausea, and this is the mean proteinuria free days and the follow-up. And in minimal changes thereafter, we have been using intravenous monthly cyclophosphamide infusions. This is another child who had onset of nephrotic syndrome at 7 years of age, did not respond to 8 weeks of steroid. We biopsied him, he has FSGS, And we used intravenous cyclophosphamide, but this time in a higher dose, and he attained sustained remission. Last follow-up was 8 years later, and that time he continued to be in sustained remission. So this was a study which was published in focal segment intravenous cyclophosphamide in focal segmental glomerulonephrosis, steroid resistant. And what we found was that there was a 2/3 remission rate. At that time, we found that it was far more economical compared to the original cyclosporin. There was no generic versions available. And if these children had secondary steroid resistant, which means that they had a relapsing course earlier and had become steroid resistant, they tended to do better. Subsequently, obviously, we have had other agents like tacrolimus, and therefore that has emerged as a frontline agent. So this is a child whom I managed when I was at STPGI Lucknow, who presented to us nearly at 11 years of age. No response to 4 weeks of prednisone, was steroid resistant. We biopsied him. He has mesangial proliferative glomerulonephritis. We treated him with monthly cyclophosphamide, no response. We then used cyclosporin, there was no response. So he was cyclophosphamide resistant, intravenous cyclosporin resistant. We treated him with tacrolimus, which we had just started using in kidney transplants, and there were anecdotal case reports of this use in nephrotic syndrome. And to our great relief and surprise, in 4 months he attained remission. The proteinuria urine protein creatinine ratio decreased from 7 to 0.27. And thereafter, when we stopped this drug at about 6 months, this child did relapse. But then we treated him with steroids and he responded. This is our paper, which was published in Nephrology Dialysis Transplantation, Tacrolimus, a new therapy for steroid-resistant nephrotic syndrome. We studied 22 children. Mean age of onset was 7.3 years. The mean time to achieve remission was nearly 2 months. The mean dose in our experience was about 0.18 plus minus 0.07 milligram per kg. A mean duration of follow-up of 290 plus minus 126 days. 84% of our patients with steroid-resistant nephrotic syndrome attained complete remission, 11% partial remission, and 5% were non-responders. And this was one of the first papers highlighting the use of tacrolimus in steroid-resistant nephrotic syndrome, subsequently validated by other studies from different centers all over the world. Now, this is a paper by Dr. Baga's group comparing our two regimens, intravenous cyclophosphamide versus tacrolimus. 131 patients randomized to receive tacrolimus for 12 months or 6 monthly infusions of intravenous cyclophosphamide and alternate day prednisone. What they found was that the complete remission rate was significantly higher in the tacrolimus group as compared to the intravenous cyclophosphamide group. But I think it could be partly accounted by the fact that there was a slightly higher number of patients for minimal change disease in tacrolimus as compared to the cyclophosphamide group. So more difficult patients in the cyclophosphamide group, more FSGS here, which is why you found a better response with tacrolimus. This is another paper published in American Journal of Nephrology on intravenous cyclophosphamide versus tacrolimus and nephrotic syndrome. And they found that there was similar efficacy in steroid-dependent, steroid-resistant FSGS as manifested by reduced proteinuria, improved serum albumin, and renal function. At 12 months, the IVCP group had 9 complete responders, 3 partial responders, where the TAC group had 6 complete responders and 5 partial responders. Then a word about rituximab in steroid-resistant nephrotic syndrome. So in your difficult to treat nephrotic syndrome patients where there's nothing else left, you could use this drug. This is the landmark paper by Toulouse et al. Published in Pediatric Nephrology 2010. They used this anti-CD20 monoclonal antibody in weekly infusions of 375 milligram per square meter for 4 weeks. 22% of these very difficult to treat subset attained complete remission. Another 22% attained partial remission. This is another paper by Magnasco et al., which didn't find that great benefit. Three patients in control and 3 in the treatment group responded in steroid-resistant nephrotic syndrome. And again, Dr. Baga's group also found that the benefits of rituximab therapy are limited in patients with steroid-resistant nephrotic syndrome, particularly those with FSGS. But in steroid-sensitive nephrotic syndrome, where you have used up everything else, I think it's a valuable agent in achieving remission. There have been studies of using combination therapies, cyclosporin, MMF, intravenous cyclophosphamide, TAC, MMF, prednisone, rituximab, MMF, and in desperate cases, we have used these therapies and attained remission. A very interesting child, which I managed when at HCPGI. He came to us in 1993 with nephrotic syndrome, no response to steroids, had focal segmental glomerulosclerosis on biopsy, cyclophosphamide resistant, cyclosporin resistant. We didn't have anything else that time. We just put him on enalapril. Later on, so there was improvement in proteinuria. Later on, losartan came by, added losartan, and thereafter this child entered complete remission. So if you have nothing else, now we didn't have genetic analysis at that point of time. So perhaps he had one of the monogenic causes of nephrotic syndrome. But what it highlights is that you can use this therapy of ACE or ARBs or even a combination and get complete remission. So dual blockade is effective. It has been used in congenital nephrotic syndrome and also in idiopathic membranous nephropathy, a very cheap and cost-effective alternative. And these are the different protocols. This was the Mendoza's protocol, nearly obsolete now. In steroid-resistant nephrotic syndrome, 66% remission rate. Our own protocol of cyclophosphamide intravenously and prednisone, 65% remission rate. Combination of cyclosporin and prednisone, 40 to 50% remission rate. TAC and prednisone is currently the gold standard, 70 to 80% remission rate. And rituximab, 44% remission rate. So these are the KDIGO guidelines, which suggest that CNI should be the therapy for all children with steroid-resistant nephrotic syndrome, treated for minimum of 6 months and then stopped if there is a partial or complete remission is not achieved. If it is achieved, the minimum of 12 months, low-dose corticosteroid therapy should be combined with CNIs. ACE or ARBs should be used, and in children who fail to achieve remission with CNI, you could use mycophenolate, high-dose steroids, combination of these agents, or even intravenous cyclophosphamide. A word about genetic testing, and it's come up in a big way now. The role is in making a diagnosis. At some non-podocyte related diseases may mimic steroid-resistant nephrotic syndrome. Even Alport syndrome has been shown to do this. So it helps us in providing genetic counseling in monogenic diseases. There are issues of incomplete penetrance, those with issue of interallelic influence of mutations. It helps avoid inefficient immunosuppressive therapy in patients with potential side effects. But yes, you can get complete remission with CNI in a subset of patients. Discovered personalized treatments. You can use CoQ10. CoQ10 enzyme has been used in those with anticoagulin and chaperone deficiency. Predicts a low risk of recurrence after transplantation. If you identify a genetic mutation, stop immunosuppression, use ACE or ARBs, and these children tend to do very well after kidney transplantation. Also helpful in selecting potential intra-family kidney donors. And disease-causing mutations have been identified in about 80 to 100% of patients with steroid congenital nephrotic syndrome, even in the absence of family history. So at the present time, genetic testing is limited to congenital nephrotic syndrome and a subset of childhood onset steroid-resistant nephrotic syndrome, regardless of family history. And we are increasingly using this in our practice. A word about kidney biopsy. This is a paper published in Pediatric Nephrology 2002, and what we said was that they should be limited to steroid-resistant nephrotic syndrome, those with atypical features like hypertension, microscopic hematuria, low complement levels, which predict non-minimal change disease, congenital nephrotic syndrome. If you have syndromic nephrotic syndrome, other congenital anomalies, or you have acute kidney injury in a child with nephrotic syndrome, then definitely you should do kidney biopsy. But in frequent relapsing or steroid-dependent nephrotic syndrome, there's not much role. Now, this is another paper looking at metabolic bone disease in children with nephrotic syndrome. One of the first few studies, and we found was that 29% of our children had severe osteopenia when we did bone density studies, defined a Z-score of below -2 standard deviation, and 57 of the 71 children also had mild osteopenia. So this is what we should be looking at in children with nephrotic syndrome. A subsequent study looking at 100 children prospectively. We looked at history of bone pains, fractures, calcium, phosphorus, PTH, alkaline phosphatates. We did the DEXA scans, and all of them we initiated in 500 milligram of calcium carbonate and 200 international units of vitamin D3, published in Nephrology Dialysis Transplantation. And what we concluded was that calcium and vitamin D therapy has a role in preventing low bone density, and these have been found now in the current KDIGO guidelines based on initial studies and subsequent studies from other centers which are validated. A word about immunization in children with nephrotic syndrome. Pneumococcal vaccination should be given to all such children. Influenza vaccination annually to children and their household contacts. We should try and defer vaccination with live vaccines until the prednisone dose is either below 1 milligram per kg or 2 milligram per kg alternate day. And live vaccines are contraindicated in children receiving corticosteroids, sparing immunosuppressive agents like cyclophosphamide, mycophenolate, or CNIs. Now, this is a very interesting child who is currently 13 years. He had nephrotic syndrome at 1 year of age. He is now 51 kgs, 146 centimeters, and as you can see, he's grown reasonably well. But this child had onset of nephrotic syndrome at 1 year of age. We biopsied him. He had minimal change disease. He was steroid resistant. That's the reason for the biopsy. So quite a relief at that time. We treated him with intravenous cyclophosphamide protocol. He did improve and became steroid dependent. So some improvement here. Then we used mycophenolate. He became frequent relapser. Finally, we ended up using levamisole. So he ended up becoming an infrequent relapser and thereafter attained sustained remission. So it reads like a textbook of nephrotic syndrome and use of multiple agents in this case. So coming to the prognosis of nephrotic syndrome in children, 80% of these children have minimal change disease. More than 90% are steroid responsive. More than 70% relapsing course. 80% long-term remission during childhood. 15 to 25% nephrotic of these children continue to have nephrotic syndrome during adulthood. So that's very important. We need to counsel the family for early use of steroid-sparing agents so we can minimize this, because this leads to significant morbidity. Mortality rates and by and large are rare. The two commonest causes are sepsis or vascular thrombosis, and the prognosis is poor in steroid-resistant and non-minimal change lesions. So to conclude, if you see a child with nephrotic syndrome, make sure he's idiopathic, subjected to standard prednisone therapy. Refer to a pediatric nephrologist if there are atypical features requiring a biopsy, frequent relapse or steroid dependent, requiring second line or third line agents, steroid resistant, certainly, and if there are complications. And this is Jackie, who was a renal nurse when I was working at McMaster University, Toronto. And this is her nephrologist, the pediatric nephrologist. And this is Jackie as a 4-year-old child. So she actually had nephrotic syndrome, but as you can see, the way she was managed, she grew up into an adult and also a useful team member. And this is a textbook on childhood renal disorders, which features, among others, recent advances in steroid-resistant nephrotic syndrome, and also the IAP textbook of pediatrics, where I have authored a chapter on genetics in nephrotic syndrome, which you can refer to. And this course is dedicated to our beloved teacher, Professor Vidya Acharya, who's been an inspiration and a mentor to a legion of nephrologists in India, including me. She was my examiner in my national boards and a great teacher. Thank you.